to the last talk by Dr. Anurag Mishra from Bhubaneswar, and he's going to talk on very important topic, physiological IOP Phaco, emerging trend in cataract removal.
Thank you so much, Bhalla sir. Thank you so much, panel. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Now, I'll try to expand this topic in the form of a few FAQs that I very commonly come across when I present about this in different podia or even during live surgeries. The first of this question is, what is physiological IOP? What is low IOP on the Phaco machine? What low IOP should you set, and how low is low? When we transgress or make our transition from the gravity-dependent machines to the active fluidics machines like the Centurion, most of us use the IOP of, say, around 80 because we've been used to hanging the bottle at around 100 centimeters height. Any value lower than this can be considered low. Most of the surgeons are happy in the 40 to 50 range of IOP while operating. But if you talk about physiological IOP, it should be somewhere around 20, 25, 24, 30. Set your comfort level, but it should be somewhere around 20. Now, the question is, if you bring down the IOP on a Phaco machine and operate under physiological conditions, so to speak, is it truly beneficial to the patient? There have been several studies which prove that it lessens the injury to the corneal tissue, the endothelium in particular, because you're not bombarding the eye with fluid. It reduces post-operative inflammation, reduced blood flow in the chororetinal vasculature. There's no increased stasis in the vasculature, reducing the chances of post-operative CAME, NAION. All these, to me, are theoretical. Let's talk about something very, very practical. Aren't we all, as ophthalmologists, always believed in the rule of the min, rule of the minimum? When we correct the myopia of a patient, the correction we give, is it not the minimal correction on the spectacles which achieves 20/20? Do we go to the max correction which gives 20/20? When we correct glaucoma, the target IOP achieved with a minimal amount of drop combination, isn't that the regime that we select for that particular patient? When we do a PRP, don't we apply the minimum number of laser spots that achieves the job, that does the job for us, and not go and jar the retina all around? And when we do a corneal suturing in case of a perf, don't we apply the minimum number of sutures which achieves the wound integrity and not go on decorating it with sutures all around? So if we believe in all these principles, we do believe in the rule of the min. So the minimum numerical value of the IOP set on the Phaco machine, which keeps the whole environment under physiological conditions, is it not beneficial for the patient and the surgeon combined? But the question is, if you go down and liberate less amount of fluid from the Phaco machine, how is it possible that the anterior chamber will be maintained for you and offer you sufficient space to do your job? So what the manufacturers have done is, there's a very tiny laser etched spot that looks like a QR code of sorts on the FMS of this machine. Now the manufacturing plant, what they do is they produce IOP fluctuations mechanically or artificially. The response of the machine is then recorded. Because it's an active fluidic system, the bag is pressed between two plates to liberate more fluid. Every change encountered and every resurrective measure that is taken by the machine is recorded and etched on onto this mark. Now, the moment you fit in this FMS into the machine, there's a blue light, there's an optical sensor which constantly looks over this. So if there is a minor fluctuation, the IOP drops a little below the preset value of 20 or whatever, then the machine starts acting immediately. And on top of that, nowadays they have an active sentry, which is an irrigation pressure sensor built right into the handpiece. So that's very close to the business end. The moment there's a fluctuation in the irrigation, it takes the measures again. Do we need to tweak other indices? If we are operating under extremely low physiological IOP conditions, do the other parameters need to be tweaked? Yes, they do. The vacuum should be set somewhere around 400 to 450. You can't say that I operate under 20 and go to 600 plus. You're bound to have surges. Even the aspiration flow rate should be bent down. It should not be set at 35, 40, which we are mostly used to. It should be brought down to 23. But the question is, if we are using such minimal fluidics on the machine, does it slow us down? Does it slow the procedure down? We'll see that in a moment from now. But there are certain other surgical factors also that you need to modify. The main port incision should not be less than 2.2 because if it's less than 2.2, it kind of constricts the sleeve and liberates even less fluid. Side ports should be as small as possible. The sleeves should get changed with time because with time, with repeated autoclaving, they swell up and cause a rigidity. And kinking, while you're introducing the handpiece, the sleeve gets kinked at times. That should be checked because the fluid you're liberating into the eye is very, very low. Now, slowing us down will be demonstrated. It's not something that you should see. So this is an unedited video. The only thing that has been cut is the changeover time from the Phaco handpiece to the eye and all that. So this is when I start. The IOP is set at 20. You can see the flow rate is at 23. The vacuum's at 445. And I initiate chopping. This is the primary chop. Would like to repeat that this is an unedited video, so one should actually keep a check on the stopwatch if one's having access to it. The primary chop complete, the secondary chop initiated, the other side of the heminucleus. All right throughout the type of nucleus and the type of case and the type of patient I handle, the IOP stays at 20. I never ever increase it to any other value. There might be some other changes in the dynamics part though. For the harder cataracts, the torsional energy might just go up a little. The IP settings might change a little. It might just give me a more bulk of part to boom the nucleus with, but not the fluidics part. So this is where we are closing in on the nucleus. The epinucleus is there, and then the cortex. All that will be removed in one go after that. So this doesn't slow us down. The next question, due to paucity of time, I have actually cut down on a lot of videos. But just to answer this question, does it work for all cases? As I explained, it does work for all cases for me. And I deleted a lot of videos due to paucity of time. I'll just pick up one which is really, really hard. And as I said, the IOP stays at 20. The only thing that has changed right here, if you could see from the last case, is the VAC has increased to 500 and it has not stayed at 450. So the vacuum has increased to 500 in this case. And the torsional power now scales up to 70, particularly for the chop mode. The longitudinal Phaco essentially is 0, and the IP settings have changed a bit. I would not like to take you to the details of the IP settings and where I keep them for harder cataracts because it actually needs some amount of understanding. But again, if you look at the CDE, there also I'm acting like a miser, not spending a lot of energy. And we are through with the chopping almost, and the CDE has essentially stayed less than 4, which is actually commendable for any procedure, because for a cataract which is of this sclerosis grade, which will be close to a 4 or a 4 plus, any CDE, if you're managing the whole case with the CDE being kept below 15 or 16, you must pat your back saying that you've done a good job, son. So we are into the quad mode already. Again, an unedited video. I just wanted to show you that neither does it slow us down, nor it forces us to expend more in terms of energy and fluidics. Even the last piece doesn't have to be handled in a slow motion because you do not see the anterior chamber flinch at all. All this with low fluidics and low IOP set at 20. I'll stop at that. Thank you so much for your kind attention.
Always a pleasure, sir, to listen to you. I just had one question. Is there any case scenario where you would, kind of increase the pressure?
So it doesn't depend on the case, but it might depend on the patient. Some of the patients are very apprehensive. They hold their breaths. Some of the patients have deep-set eyes. And if you have, that's the reason why I do not use the self-retaining speculum. I use a wire speculum. So if you're using a self-retaining speculum on a deep-set eye, it kind of puts a positive pressure from the anterior side. But that's rarity. What's more common is a patient who is more apprehensive and holds its breath, and there's an internal pressure that builds up. So in those circumstances, you might just need to scale up a little and go up. But 20 can increase to 30, and that's maybe in a 0.1 to 0.2% of my patients. And then less 99.8, it stays at 20.
Thank you, Anurag. I think that was very nicely explained because we have been traditionally using gravity-dependent IV poles and oblivious of the fact that a bottle height of 105 centimeter causes intraocular pressure close to 77 millimeter mercury, which is pretty high. It may not, if the surgery is fast, it may not amount to much in normal patients, but imagine such high pressure you are maintaining in patients of moderate to severe glaucoma. You may be happy with having done very good surgery, but post-operatively you will find that the field is really being affected to a great degree.
Other
Yeah.
practical point is, with the advent of modular OTs coming in, most of the groups will not allow you to keep your bottle height at 105 centimeters. That's
But
a practical
even 90 centimeter is equivalent to 66. So that is pretty high. So if you want, like you are working at 20 millimeter of mercury or 30 millimeter of mercury, imagine having double that IOP. That really is very detrimental. I think very nicely explained this.